Hi everyone, thanks for joining. We're going to get started now. Today we have approximately 30 minutes, and just a reminder, one question, one follow-up. And with that, I'll turn things over to Dr. Moore.
Good morning, everyone. It's been a month since most of our students went back to school. We continue to monitor the situation closely, and I'm very pleased that our schools continue to be safe places to learn. While we are reassured that COVID-19 transmission in schools remains low, we know we need to remain vigilant and be ready to respond quickly to potential cases and outbreaks in the context of the Delta variant, especially in areas of high community transmission. COVID-19 vaccination and extensive public health measures in place remain the primary responses to prevent the introduction of transmission of the virus in school and childcare settings. While vaccines and strategies such as masking, cohorting, and daily symptom screening measures remain the best defense against COVID-19, screening and testing remain important tools in protecting against the spread of COVID-19. To further help our schools remain safe and open, the province will support the implementation of rapid antigen screening for COVID-19 in specific schools and licensed childcare settings on the direction of the local medical officer of health. This school-based program is in keeping with current provincial guidance for rapid antigen screening and based on advice from Public Health Ontario, the Ontario COVID-19 Science Advisory Table, and Ontario's Testing Strategy Expert Panel, and it's focused on screening of children in public health units with the highest risk of transmission. Where the risk of transmission is very high and vaccine coverage is low at the community or school level, this measure may provide an additional layer of protection for schools and child care centers to minimize risk of outbreaks and potential closures. Routine rapid antigen screening of fully vaccinated individuals and children is not currently recommended given the effectiveness of the COVID-19 vaccines, as well as the risks posed by the disruption of learning as the result of false positive tests. This COVID-19 rapid antigen screening for childcare and school-aged children will proceed in the following manner. Local medical officers of health will determine if rapid antigen screening will be implemented in their region to local factors and needs. Where the public health unit has identified a need for rapid antigen screening in schools or childcare settings, tests will become available. This testing would be voluntary. Parents will be able to choose if their children participate in this screening offered by their schools or licensed childcare settings. Rapid antigen screening will be used only for unvaccinated, asymptomatic students and children who are not high-risk contacts, as in participating or in an outbreak. People who are symptomatic and high-risk contacts should continue to access lab-based PCR testing at assessment centers and other specimen collection centers. Unvaccinated, asymptomatic children will be able to conduct the rapid antigen screening at home and will be provided with instructions and necessary supports. Children who receive a negative result on a rapid antigen screening test will continue in-person learning. Children who receive a positive result will be required to seek a lab-based PCR test at a local assessment center or specimen collection center and will need to isolate until the result of that lab-based PCR test is known. Targeted asymptomatic screening could help detect cases in schools earlier and reduce the risks of ongoing outbreaks and/or closures, particularly in communities across the province that have a high prevalence of active COVID-19 cases. It is another tool in our tool chest to help keep schools safe and keep students in the classroom where they thrive. I'd like to again thank Ontarians for continuing to follow public health measures and advice that is in place. And I continue to encourage everyone who has not yet to get their first or second dose of the COVID-19 vaccination to do so as soon as you can, to increase our community immunity and protect our young Ontarians who are not eligible to receive the vaccine as of yet. Thank you.
We'll go to the floor for questions. One question, one follow-up.
Dr. Moore, last week the Kitchener company that was supplying kits to parents was told by the Ontario government to stop. I'm just wondering why, and if parents wanted to take this on themselves and add an extra layer of protection, what's the harm in that?
I believe the Kitchener program, and I'm not familiar too much with the details, was part of the PASS program. The PASS program was for businesses only. They had specific objectives and deliverables for that antigen testing program, and it was not to be used in schools. Now we do have a tool to be used in schools that will be available based on a decision by the local medical officer of health in partnership with the school boards and parents. And it should be a targeted, high-risk strategy to keep schools open. That is the best advice from Public Health Ontario, from our testing team, as well as the expert panel.
Just on a separate topic for a colleague of mine, Thanksgiving weekend is coming up. What would be your recommendation to families that would like to get together this weekend?
So on Thursday, we're going to announce the recommendations for Thanksgiving. We'll also mention for Halloween. But in a nutshell, if you're having family over and you're completely vaccinated, if you feel comfortable removing your masks, that would be absolutely appropriate in a fully vaccinated group. We still have the reopening of Ontario maximums of 100 outdoors and a social gathering and 25 indoors. Those should be adhered to, and I think those are reasonable and safe numbers. If it's a mixed group of vaccinated and unvaccinated individuals outdoors, you may consider keeping masks on, and certainly if you go indoors, I would suggest you keep your masks on in a combination of groups of vaccinated and unvaccinated, particularly if you're vulnerable to this virus. So if you're older, you have any chronic medical condition, and you're mixing in with unvaccinated individuals, I would suggest keeping your masks on. And certainly anyone that goes into a social environment where we're close with family members, you'd want to screen for any symptoms of COVID-19. If you have any symptoms consistent with COVID-19, you'd want to be tested in advance and ensure you know the results before you go to a social setting. Every long weekend like this, especially Thanksgiving, where it's a social event where we have families getting together, we want to minimize the spread. We want families to embrace the opportunity to get back together for their mental, physical, social well-being, and we'll have that list of recommendations available on our website soon, and we'll announce it on Thursday as well.
Hi, Dr. Moore. First question is, the Premier's office has been pointing out that till now, the Testing Expert Advisory Panel, Ontario's COVID-19 Science Advisory Table, and yourself have all been advising that widespread asymptomatic testing of students isn't recommended because of its impracticality. Is this still your position, or do you feel that the announcement you're making today clashes with that?
No, it doesn't clash, and we've reviewed this testing strategy in the face of Delta. We know Delta, COVID-19, wants to spread from roughly 1 person to 7 susceptible individuals. It's aggressive, and it has a higher virulence, so it puts more people into the hospital. And in the face of Delta, we want to have this testing available for a risk-based strategy. We still, all of those 3 expert groups do not recommend widespread testing of the 2 million children that are going to school on a daily basis, or the 300,000 individuals who are vaccinated. The strategy remains targeted, high risk, and there are, we spoke to the medical officers of health yesterday. There are some medical officers of health that are already interested in putting this in play to keep schools open, and the testing will be available as of next week. We want to keep schools open. All medical officers of health are in agreement that schools should be the first to open and the last to close. And this is an extra tool in our tool chest to keep schools open and to have the antigen tests accessible and available if we're seeing a school that's in trouble, that's having consistent cases, that's at risk for closure. This is an extra tool to keep our children in the classroom.
Okay. You mentioned too that these tests would be deployed, of course, at the direction of the local medical officers of health. So will the provincial government meet any and all requests, or will it itself base whether it sends antigen tests to each community on a certain threshold, for example, by the case rate in the community or in the school itself?
Yeah, thank you for that question. It is a decision by the local medical officer of health. They can consult the office of the chief medical officer of health, where we have regional consultation processes in play, and certainly we're happy to provide guidance and support to our medical officers of health and in partnership with their school boards. They will be the ones identifying what schools they think are at risk, where there are trends in the community that they have high pockets of unvaccinated individuals and or high risk of transmission in the school settings. Those are the real targeted schools where we want them to stay open and to stay safe, and it'll be a consultation. If the medical officer of health requests it, they will be provided to the school board, and the testing will start. And we anticipate next week being the beginning of that testing phase for the rapid antigen process.
We'll go to the phone lines. Just a reminder, one question, one follow-up.
Your first question comes from Chris Herholt with CP24. Please go ahead.
Good morning, Doctor. Can you just speak to me about what a target school or childcare center would have to display? Is it, you said consistent cases, is it cases with no epidemiological link? Is it, context of contacts, fear of aerosol spread? Like, what exactly would you tell a local medical officer of health to look for in a school that should be, that these tests should be deployed to?
Yeah, so it really does come down to a judgment, and it's a judgment of what's the risk in the community that surrounds that school, so what's the level of activity of COVID-19 in that community. A number that we've looked at is around 100 per 100,000. Now, that doesn't have to be widespread in, let's say, take Toronto, for example. Toronto's level of infection is well below 100 per 100,000, but there could be areas of Toronto that have that high a risk, and so the medical officer of health and school board partners could identify that area of an urban setting that meets that threshold of high risk at a community level, and then put antigen testing in play in advance of activity in the school setting. And or it could be responsive to increased detection of cases in the school setting, and or in outbreaks in the school setting. So it'll be a number of factors: the community level of risk, the percentage of the population that's been vaccinated, and I'm just so happy we're at 86.5% of the population today with their first doses across Ontario of eligible, which is remarkable achievement. So the risk is coming down in most communities, but there are pockets where we don't have that high level of protection. Then you'll be looking at the history of activity in that school, whether it's in the occupational setting or the school setting. Have they had a history of outbreaks? Have they been at risk for closure? And if all of those boxes are getting ticked, and it's the judgment of the medical officer of health that we should have their rapid antigen testing in play as a tool in the tool chest to keep them open, they will receive the testing at the school level in partnership with the school board as well as the medical officer of health, and it can be implemented. Again, it's a voluntary process for parents to have the test done, but it is, I think, a valuable tool to keep schools open, which I think is the ideal for all students, all parents, and workers in those environments.
Follow-up?
Doctor, if the supply of tests that the province has access to is relatively stable, if the federal data is to be believed, and all three of the expert groups that advise you are saying that this isn't necessary on a widespread level, why are you doing it now?
We're doing it now because I think over the last several weeks we've learned that there is a place for this type of testing, especially in the face of Delta. We've been reviewing the literature around the globe, in particular from the UK and some areas of the United States that have implemented testing, but they have much higher rates and risk than ours. And we do see it as a tool that can be used, in particular to keep schools open. We've been working diligently with our school boards and our medical officers of health, local public health agencies to keep schools open. And it saddens me every time we have to close a school for a brief period of time to get a round of testing or have to quarantine students for the 10 to 14 days. When that occurs, we're looking for any other new interventions we can put in play to minimize the disruption for parents and for teachers and workers and to keep that school open, but to do so safely. And we do think the rapid antigen testing has that defined role where we're seeing risk of transmission, risk in the community, to keep that school open in a very targeted and risk-based way.
Next question.
Your next question comes from Adrian Gabriel with City News. Please go ahead.
Good morning, Doctor. A bit of a follow-up on that question. Considering that I believe it's nearly 1/3 of all active COVID cases in the province right now are in school-aged children, why has it taken so long for us to get to this point? We're a month into the year. Why wasn't this up and running for day one of school?
Well, we did review the data and the implementation of rapid testing, and initially our expert panels did not recommend it, certainly at a population level for the 2 million students that are attending on a daily basis. And we've now watched the data, we've learned from international experience and learned from our local experience that we do think there'll be a targeted role for rapid antigen testing to be put in play. This is all new to us as we reopen the school system, and our goal is to keep our schools open and safe, and we do think this tool will help us in that battle against the Delta variant, given its higher transmissibility. I will say, though, and I thank the students and the parents and the schools and the local public health agencies have worked diligently. The outbreaks, which could have been from 1 to 7 to 49, if you follow how Delta can spread rapidly, have usually been from 1 to 2 to 4 students, and we haven't seen a significant amount of ongoing transmission. And that the schools basically reflect what's going on in the community. And our communities across Ontario have been able to keep our rates of infection to be one of the lowest in all of Canada, and for that I just have thanks to the parents, to our communities, because it's keeping the community rate low will keep our schools safe and keep our schools open, and we're still have that last mile to go to get our vaccination rates to a level above 90%, which I think will really slow the virus down. We're slow at 86.5. If we really want to protect our schools and our communities more aggressively, we need anyone that's still considering to be vaccinated to come forth and get vaccinated. That is the true means by which we protect our communities, our schools, our businesses, and keep them open as we head into the winter months.
Follow up. Adrian?
Adrian, you may have us on mute.
Sorry about that. Thanks for that answer, Doctor. You mentioned the importance of multiple measures to keep schools safe, cohorts being one of them. City News has been following the reorganization of schools in the Toronto area. Upwards of 40 Catholic schools, at least 40 Catholic schools in the Toronto board are reorganizing their classrooms, which means that cohorts are going out the window. The Science Advisory Table has recommended that elementary schools have the smallest class sizes as possible. The Ministry of Education and school boards are currently reorganizing classes to maximize class sizes based on pre-pandemic algorithms. 10% of classes will be above pre-pandemic class targets. Do you think that this is counterproductive when we are moving teachers and increasing class sizes during a pandemic?
Well, I hope they're doing any changes in consultation with their public health agency. I guess that would be Toronto Public Health. And they're taking into consideration the risk of increasing class sizes or mixing of cohorts. I know many areas of the province that are seeing transmission in schools are trying to minimize the interaction of the various cohorts. They're trying to minimize the combined lunches and having people have their lunches back into their classrooms, minimizing the mixing of cohorts out in the schoolyard. And that keeps our schools safe and minimizes disruption. So I hope if they're doing changes, they're doing it in consultation and in consideration that COVID-19 transmission is an ongoing concern. Certainly we want vaccination to be available to the 5 to 11-year-olds, and we're in regular contact with our federal government to ascertain when those vaccines will be available. Those will make our schools safer as well, but they may not be coming till early winter. And in the meanwhile, we still have to deal with limiting the spread of this virus in our school settings, and it should be always safety first.
Next question.
Your next question comes from Chris Rishoey with the Toronto Star. Please go ahead.
Hi, thank you for taking my question. I'm just wondering if this type of testing, especially if you're using it in an outbreak, do you think it could mean the end of entire classes being dismissed or entire schools being shut down at some point? Like, what do you envision the impact of this being?
Well, thanks very much for the question. So for outbreak management, if there is a risk of transmission in a classroom, all of those high-risk contacts would be asked by public health to get a PCR test. And when we're seeing widespread transmission in a school, I've seen examples where public health has asked the whole school, so 200 children, to get a PCR test. If that PCR test is negative, the introduction of the rapid antigen testing could allow those children to come back quickly if they're asymptomatic, and for them just to get rapid antigen testing on a regular basis to keep that school open, to prevent those children from having to quarantine at home, and to prevent closures. So we do see the interaction of outbreak management using PCR and then subsequent application of a rapid antigen test strategy over the pursuing weeks as a means of keeping our schools safe. So that's one component of outbreak management. And then if it's a high-risk school in a high-risk setting with low immunization rates, you could apply rapid antigen testing on a regular basis to minimize outbreaks, to detect cases early, and to protect the community at large through enabling case finding by public health, because most of that transmission would have been in the family or social setting rather than the school setting. So the combination of the testing strategies, both PCR and rapid antigen, it was a great question, can be used in outbreak management, can be used to keep the cohorts in class, and can be used to help detect cases in the community through those multiple means that I've described.
Follow-up?
Yes, thank you. I also wanted to ask about the frequency of people with medical exemptions. Do you know, for example, what the general incidence of medical exemptions in the population for legitimate conditions would be? How many per 100,000?
Well, good question. So medical exemptions principally are, number one, a severe allergic reaction to any of the components of the vaccines. And it's our belief that that should be around 1 in 100,000. And that should be confirmed by an allergist. And even the allergists, when they assess patients, have found that they're able to give a second dose safely to those individuals who thought they had a severe allergic reaction. So that would be roughly 1 in 100,000. The other is the risk of inflammation to the sac of the heart, pericarditis, or the heart itself, so myocarditis. That risk varies. Again, it's around 1 to 5 per 100,000. It's higher in younger age groups, and as we've said, we have a preference for one vaccine over another for 24 and under for the Pfizer vaccine because it has a lower risk of myocarditis, pericarditis. And so roughly, if you put those calculations together, we should be seeing medical exemptions at the risk of around 1 to 5 per 100,000 if you combine those two risk scores. We're seeing that higher reported by workers, and I think it deserves a review. And certainly we've tried to educate physicians, nurse practitioners who fill out these forms to ensure that they are aware of the two major medical exemptions for these vaccines.
Next question.
Your next question comes from Caroline Alfonso with the Globe and Mail. Please go ahead.
Hi, Dr. Moore. I have a question on the rapid test strategy. Why couldn't you allow this strategy along with the parent-led preventative strategy that would have been designed to keep, cases out of schools, keep children safe? Just going back to an earlier question, what's the harm in that?
Oh, a great question, and it all has to do with the features of the tests themselves. And so the expert panels have reviewed the sensitivity of the test, its ability to pick up a true positive case. And when you apply these tests in a low-risk setting, you'll find that you'll get more false positives than true positives, and you'll send people for PCR testing as a result, and they'll be off school because they have to wait for the result of the PCR if the antigen's positive. So in a low-risk setting, the benefit of this testing results in too many false positives, too many children off getting PCR testing, and a cascade of unnecessary testing. And that's the opinion of all three of our expert panels, that it really should be a risk-based strategy to avoid children being off school waiting for a result that's going to come back negative in the on the PCR, because it's the more sensitive and specific of the tests. And I know this is somewhat complex in terms of the math and the understanding of the sensitivity of each test, but this is well-known medical procedure to understand your probability of a test before you apply it. The pretest probability is very important when you're ordering tests, and we don't like ordering tests when the pretest probability is exceptionally low.
Follow-up?
So if there's a worry then about false positives, then why give it to businesses?
The business strategy is not one that I personally was involved in. It was part of a different level of the government. I do believe that there's less and less testing being done in the business community as we have more and more individuals embracing the immunization strategy, which is the strongest benefit for workers and keeps workers present and minimizes their personal risk. So I do believe testing in low-risk environments is a second best to vaccination. But if you have a worker that's not willing to get vaccinated, that is another tool. But there's always the risk that you'll get false positives in a low-risk environment.
Next question.
Your next question comes from Colin DeMello with CTV News. Please go ahead.
Hey, good morning, Dr. Moore. Yesterday we learned that roughly 80% of education workers are currently vaccinated, which means that 2 out of every 10 education workers, teachers and the such, are unvaccinated right now. I'm wondering if you feel like that is an acceptable level of vaccine coverage among educators, and whether you feel like a mandatory vaccination policy would be the right tool now to increase those levels.
Thank you for that. I do find it surprising. So I do believe a number of workers in that environment haven't reported as of yet. I would find it surprising if they're below the provincial average, which is 86.5 today of first doses and 81.3% of second doses. As workers in a I would say a social high contact environment, I think immunization is exceptionally important for them to minimize their personal risk and minimize the risk of transmission in that setting. I do believe they have very good infection prevention and control, so they have masking, they have shields, they have hand hygiene, they have screening, all of which are important as well. I would hope as we head further into the winter that the workers in the education sector realize the benefit of immunization. They realize that the vaccines are safe and highly effective at preventing hospitalization, admission to the intensive care unit setting. This truly is an ongoing pandemic of the unvaccinated in Ontario at present, and I would hope that they will embrace immunization. We do have a strong layer of protection, though, of vaccination plus infection prevention control plus testing, but I would hope we'll see continued rise in numbers for those workers with vaccination. I personally am disappointed if it truly is 80%.
Follow-up?
Okay, and so on the other part of that question, I mean, obviously you have education workers and healthcare workers who are still unvaccinated. They've had the better part of a year to go and get their first and second jab. At what point will you make it mandatory for healthcare and education workers to go get a vaccine, similar to what you did in long-term care, which was that they have to get the vaccine or they cannot have access to those facilities? Can you tell us whether or not mandatory vaccines will be in place for healthcare and education, and why or why not, please?
So I fully support the Minister of Long-Term Care, Minister Phillips' directive on mandatory immunization in long-term care. We had to learn from the first, second, and third waves and prevent deaths, hospitalization, morbidity in that sector. So I absolutely applaud the minister putting that directive in place. It was fully supportive, and he knew I was fully supportive of a mandatory immunization in that sector. To me, that was the highest risk sector that had the worst impact of the pandemic on their population. And my heart goes out to all the families that have lost their loved ones from COVID-19, and have to celebrate the workers that stayed in and provided care and provided respect and dignity for their patients. So we have together worked at getting a mandatory immunization policy in place for that sector, as well as the third dose strategy for patients. I'm happy to say that over 66% of patients have allowed us to provide them with the third dose, so an extra level of protection for them as we head into the fall and winter. And that we continue to provide infection prevention control and auditing to ensure that population is protected. The next priority for me is the acute care sector, and I'm daily monitoring the immunization rates through the Ontario Hospital Association, through CEOs of hospitals, to ensure that we're making progress on immunizing the acute care workers. I think it's a patient's right to know whether their healthcare worker that's treating them for their cancer or for their transplant is immunized, and that they are at low risk for transmission in the acute care sector. And I support the hospitals that have moved to mandatory. Our directive allows a hospital to do a risk assessment and to move to a mandatory immunization policy anywhere in Ontario. And I think around 40% of hospitals have moved in that direction, and I'm absolutely supportive of them doing that. They are now achieving the rates that I think are high enough to protect their workforce as well as protect their patients. We'll monitor this data on a regular basis. So my immediate priority was long-term care. My next priority is acute care, home care, ambulance services, independent health facilities, and then we'll be monitoring the education sector and hoping that they increase their immunization rate well above 80%, which is below our current population rate.
Last question.
Your final question comes from Paula Lareggio with the Canadian Press. Please go ahead.
Good morning, Doctor. You said earlier today in response to another question that we're seeing higher rates of medical exemptions than the 1 to 5 per 100,000 than it should be. So could you clarify what we are actually seeing in terms of medical exemptions and what is being done to kind of review that?
Yeah, I've heard, let's say through hockey leagues and or through employers of a 1 to 2% medical exemption rate. To me, that does seem high, and we have to have physicians and nurse practitioners better aware of what the true medical exemptions are. If they're not using the appropriate form that we've asked medical exemptions to be documented on, the form should document the exact medical exemption, the duration that that medical exemption should endure, as well as contact information for the physician, their licensing information as well for the physician or nurse practitioner. So the partnership with the colleges, the College of Physicians and Surgeons, College of Nurses, is ongoing to educate medical and nursing experts that what the medical exemptions are, and to try to improve on their knowledge base. So it is an ongoing quality improvement initiative on informing them of what the true medical exemptions are. I want to ensure that all Ontarians have the benefit of protection of immunization, and a false medical exemption or an incorrect one bypasses our ability to protect them. So I would hope that these conversations are happening between physician and patient, nurse and patient, and that physicians are seeking guidance from their respective college regarding what are the appropriate medical exemptions.
Follow up, and this is the last question.
You also mentioned earlier in the answers getting ready to vaccinate children who are younger as soon as the vaccines for younger age groups are approved, potentially with a start in the winter or sometime around then. The province hasn't really said anything about what the plan is to vaccinate kids under 12, aside from starting a working group. So can you give us an idea of what the plan would be and how it would be different from the campaigns underway to vaccinate the rest of the population?
So we have a vaccine task force. We meet weekly and provincially, we meet every morning to discuss the administration of the vaccines across the system. I can tell you that all doors will be open to the 5 to 11 year age group, whether it be through pharmacy, through immunization clinics in partnership with public health, and or in partnership with their primary care providers. We will leave all doors open to be able to immunize this age group. We still don't have details, though, of when we're receiving vaccine, how much vaccine will be distributed, whether we have to provide the vaccine by age group or by comorbidities, like we did in the early days when we didn't have a large amount of vaccine delivered all at once. So we have created a working group that will prioritize what populations between 5 and 11 should receive the vaccine first, what age groups, what medical conditions, and most likely do it in a descending order and with medical conditions as a priority. So all that work's getting done. We just need some details from the federal government on how much vaccine, when, and how we can distribute it. But I can assure all Ontarians and all parents that the work is being done, and when we get details on vaccine delivery, we will be prepared to be able to provide it. And we're working with the Hospital for Sick Children to be able to provide an information line on any questions regarding the vaccine. We're also working on knowledge activities to inform parents on the risks and benefits of the vaccine through our pediatric working group and child expert group. So the work's getting done. We just need a little more detail on when Canada will receive vaccine, and then Ontario, and what quantity and what time.
Thanks, everyone.